People at UT El Paso and at Pan Am, can you all see this board here? I'm going to be writing on that board. Can you all see this from where you are? I see quizzical looks in El Paso.
Nod your head away.
Well, you know, we can see it as long
Yeah,
as
they
you
can see
write
it.
with bold print.
I promise to write with bold print. Okay, I promise to do that. Actually, you should have a one-page handout from me that's called the Disablement process, which is a single sheet that has some 4 words on it: pathology, impairment, functional limitations, and disability. Do you all have that?
They have it at the sites. We don't have it here.
Okay. Do y'all have that at the sites where you're at? El Paso does not have it?
That's right.
I apologize. I'm sorry. Okay. Well, let me tell you what I would like to do in the next 40 or 45 minutes. I basically want you to come away with a conceptual model for how to frame thinking about the ways that people become disabled, in the many different ways that people become disabled, and understand that you can use this framework to design programs and interventions to test whether or not you can either slow down or reverse the development of a specific disability. So that's really what, if you come away with nothing else after the next 40, 45 minutes, that's what I'd like you to come away with. Now let me tell you a little bit about myself and where I'm coming from in this. I'm a physician, an epidemiologist, is my research background, but as a physician I'm a geriatrician. I take care of older people, and I regard myself as doing primary care internal medicine for older people. So every week I am working with patients and their families to try to figure out ways how to maintain health and keep people going for as long as possible and keep them as functional as possible. There are many times where, because of illnesses like Alzheimer's disease or other problems, we can't cure what's going on, but we can always provide comfort and care and try to keep people as active as possible and as engaged as possible with their families and other people. In my research, what I'm interested in is the epidemiology or development of disability. And I've been working for the last 6 to 7 years with a colleague of mine, Dr. Helen Hazuda, who's a sociologist, to study people in San Antonio who are both either Mexican American or European American, and contrast between the two cultures how people move down this disablement process from the point where they have an illness to the point where they actually may or may not become frankly disabled, and try to figure out what the steps are along the way. And hopefully by identifying those steps, we would be able to come up with ideas or interventions to reverse them. And I will give you some examples as we move through this. Okay, so that's a little bit about me and where I'm coming from in this presentation. Let me throw out a question and ask people if you have does anybody in there have an operational definition for what a disability is? You can just sort of generalize and think about disability. How would you frame that?
The inability to perform ADLs.
Okay, the inability to perform activities of daily living. Okay, that would be one. But can you think a little bit more globally than just ADLs? I mean, generalize from that. ADLs are important because if you can't do them, somebody else has to do them. But just if you think, philosophically, could you define disability?
The inability to exist independently.
Okay.
In just an environment.
Okay. Well, okay. You're actually getting to more profound. Pardon me?
Having quality of life, not just increasing in age. We don't have quality of life, being able to work love, and live.
Okay, so to be socially engaged in your environment. Is that right? So that you have some quality of life that you're just not existing? Okay.
Right.
All right. Well, let me give you a research definition, because what you can then do is if you set up an operational definition, you can then figure out ways to measure it. And that's what the importance of operational definitions is in any case. But in any task, okay, there is a demand. Okay. So let's say the task is I want to run a marathon. Okay. The demand to run a marathon is 26.2 miles of constant pavement pounding, bone jarring activity. All right, and that's a demand for that specific task. Okay, then at the individual level, there is the capacity to do that. All right. So what are the abilities that the person brings to do the task? Now, for our friends in El Paso and in Pan Am, can you read what I'm writing on the board here?
Yes, we can. Thank you.
Okay. If you can't read it, please speak up, and I'll write larger, and we'll go from there. Okay. So any specific task has a demand, and then the individual has the capacity, and disability is defined as the gap between an individual's capacity and the demand of the task. All right? Now, I threw out running a marathon. All right? As I'm standing here in front of you today, I am disabled from the ability to run a marathon because I don't have the cardiovascular capacity or the mental capacity, or will, if you will, to undertake that particular task. Now, so disability varies with the task that you're trying to undertake. Okay? If I wanted to walk a mile, if I wanted to reduce that demand and just say I could walk a mile, as I'm standing here in front of you today, I have the capacity to do that, and I am not disabled from that task. All right? Now, does anybody care whether or not I can run a marathon? Nobody in the room here in San Antonio cares, all right? And they shouldn't, because it doesn't make a dime's worth of difference to their lives whether or not I'm able to run a marathon, okay? It doesn't matter to society. So from a societal perspective, where things become important is when people can no longer undertake those tasks in themselves which allow them to remain engaged in society. And those can be operationalized and thought of as the instrumental activities of daily living, such as being able to manage your finances, to drive a car, to get around on your own, to do meal preparation, to go shopping, those kinds of activities. And then at an even more basic level, being able to perform your self-care tasks like the basic activities of daily living, so that you can't put on your clothing, you can't bathe, or you can't eat in the most extreme circumstances. Okay, now those are important because if somebody can't do those tasks and support themselves, then somebody else has to do it for them. So then the burden then gets placed on either the family to do it, or it gets placed on society to do that. So, for example, let's say somebody who doesn't have a family and is dependent in their ADLs and doesn't have much in the way of financial resources may wind up having to be in a nursing home, and the state picks up the costs of taking care of them in the nursing home, and there are people who take care of these basic care needs inside of that facility. And that's an extreme form of a disability, but everybody has a direct interest in this. First of all, because it could happen to any of us, and I think we should be empathetic and understanding about that. But secondly, because society has to pick up the cost for taking care of this and provide the resources for doing it. Okay. So the concepts or the things that I need for you to remember is that the disability is task-specific, and it is defined as the gap between the demand of a specific task and the capacity of the individual to undertake that task. Some disabilities are trivial, such as Michael Lichtenstein's inability to run a marathon. Some disabilities are incredibly important, such as a person's inability to bathe themselves or dress themselves. And in between, there are all different levels along the way. You know, I can't run a marathon, but I'm still capable of performing my job as a physician and being a father to my children and, you know, a husband to my wife, fulfill all the roles that I have in society. Okay. Any questions at this point? So that's a fundamental concept. Now, on the one-page handout, and again, I apologize that it's not at our friend sites in El Paso, and I hope that the people in Pan Am have it. This one-page handout there's a reference which I would encourage people to read because it's a fundamental reference, and it's called the Disablement Process Model. And it's written by a woman named Lois Verbrugge, that's Verbrugge, and Alan Jette, Jette, and it was published in 1994 as a conceptual piece, and I think it's Social Science Medicine, and the reference is there. But if you just looked up Lois Verbrugge, Verbrugge, and did a search on her name in a Medline database, this would pop up and you'd be able to find it. This is a gangbusters paper which really lays out the framework very, very nicely and very clearly. Okay. I'm going to take this. Okay, so how do we get to disability? Well, the first thing that happens in this model of Verbrugge and Jette's, well, let me back up. There are two components. There's what's called the main disease disability pathway, how you get from an individual disease down to disability. And then this pathway is set into a larger environmental context, okay, where there can be modifying factors which might change the development of the disability. So what I'm first going to do is I'm going to outline the main pathway, and then we'll talk a little bit about how things might be modified from the outside. So where things start is that there may be a disease that develops, okay? And this would be, you know, a genetic illness or something that people might be predisposed to that they get, such as, you know, diabetes or high blood pressure. And then the disease may be quiet for a while. For example, and I'll use high blood pressure as an example, okay? I think everybody agrees that hypertension is an important public health problem, okay? And you know, it's characterized by just measuring high pressures in, with a blood pressure cuff in the arterial system. And if you have uncontrolled high blood pressure, this can lead to congestive heart failure, it can lead to heart attacks, it can lead to strokes, it can lead to renal failure, right? Okay, but most people who have high blood pressure may not even know that because it produces no symptoms. And they can walk around and be perfectly fine and not disabled by their high blood pressure, okay? So you can have a disease and not have any consequences from it in the early stages. Okay? Now, the next thing that happens, though, is that the disease may last long enough or be severe enough to produce an impairment. Okay? Now, an impairment would be some kind of measured abnormality that does not yet affect function. Okay? So let's say, for example, in our case of high blood pressure, again, I hope you all can read this from where you are out in El Paso. Hypertension could lead to thickened heart muscle, okay, left ventricular hypertrophy. Okay, but that heart muscle may start thickening, and we might be able to measure it with an echocardiogram, But the person may still be able to walk and get around and do just fine without having any symptoms related to it. Or their kidney function may decline a little bit. So like their creatinine, which is a blood test that we measure to measure kidney function, instead of being around a normal value of 1, may increase to 2, which is clearly abnormal, but is still enough for the person to function. Okay? So the disease can create some impairment. Then these impairments can progress to the point where they can start interfering with a person's ability to do simple tasks. And those are what are called functional limitations. Now, functional limitation are generic activities. So, for example, like your ability to walk or your ability to get up and down from a chair. These generic tasks that we use in every single thing that we do in our lives on a day-by-day basis. Okay? So again, thinking about our hypertension example, the disease leads to some thickened heart muscle, and the heart starts not to work quite as well. Okay? And people start experiencing something like maybe a little bit of breathlessness when they walk, and they can't breathe as well. So that would lead to an inability to, let's say, walk as much or do the same kinds of tasks that you might want. But you still might not be disabled. So let me give you an example. We have some large grocery stores in San Antonio with long aisles. And if you're an older person who walks into one of these large grocery stores and you look at this aisle, it's like looking at this runway that you've got to go down. And if you're starting to have some trouble with your heart because of hypertension, you might not be able to walk down those aisles as readily as you were before to be able to do your shopping, because the distance and the demand of the task is now greater than what you're capable of doing. Does everybody see that or understand that? Okay? Now, you may still be able to shop if you wind up adapting what you do to be able to do the task and to accommodate to your impairment and your functional limitation. Now think about the shopping example and going to the grocery store. If you have some breathlessness going down that aisle and doing your job or doing your grocery shopping, what kinds of things can you do to overcome that so that you can still do your grocery shopping?
Stop and rest.
Okay, we have a stop and rest. That's one example.
Use one of their little motorized
You can get
carts.
one of their little scooters if they have one, or go to a store that doesn't have as long an aisle.
Okay, great. I mean, these are great environmental suggestions, and I hear this from my patients all the time. They might go to a smaller grocery store. They might use the scooters, although some people are embarrassed to use the scooters because they don't want the stigma. There's some people who are not embarrassed at all and they run over other people. Other things that you'll hear people say that they do is like they'll take the cart and they'll lean on the cart and they'll use the cart for support. And then a very common one is to actually stop and rest or to slow down and just budget more time to do the shopping. But they still get the shopping done and they're not disabled. Okay? But they may have a functional limitation because their heart isn't working quite as well and they can't walk as far and they can't walk as fast. Okay? Does everybody understand that so far? Okay, then, and you've done a great job of talking about how people can adapt. Now, and I hope you can see the bottom here. What I'm writing is that sometimes the disease can progress to the point where the functional limitations are severe enough so that the person is actually frankly disabled and cannot do the task even without the adaptations. Okay? So even though they rest and they're tired, even though they have a scooter, even though they're going to a smaller store, that's not enough. Their breathing is so bad, their heart is so bad, they're now in heart failure that they can't do their shopping and somebody has to do the shopping for them. Okay? Now, you can draw out this main pathway, this main disease disability pathway for any disease, illness, or condition that you want to think about. Okay? And if you take something like hypertension, all right, and I used the example of the heart, but hypertension may also cause strokes or transient ischemic attacks, which would lead to different impairments and which would lead to different functional limitations and different forms of disability. Okay? So you can have, actually I can't think of many diseases that I deal with that just lead to one impairment and one functional limitation and one specific disability. But most of the time it's multifactorial and it's hitting in multiple areas. Okay. Any questions at this point? All right, so this is the main disease disability pathway. Well, let me ask you a question here. The adaptations that we talked about, the adaptive strategies, what level were they at? Were they at between the disease and the impairment, between the impairment and the functional limitations, or between the functional limitations and disability? Where were they being applied? The slowing down, the using the scooter, the going to the smaller store.
I think it starts with your
Pardon me? I didn't hear you. I'm sorry.
I think it starts with an awareness of your impairment, and then it gets to the point where you feel you have to adapt. You have no choice.
Right. And the awareness probably starts somewhere in here around the time when people get functional limitations, when they actually recognize that there's something going on, which is they're having to change the way they have to do it. Now, sometimes people have no insight into this. It happens so gradually. Okay? But lots of times people can be aware of it, and if you ask them in an open-ended way about how they've dealt with something, they can describe the adaptations that they've made. Now, but most of the adaptations that we've talked about so far have come between the functional limitations and the disability. Could somebody, and if you put those adaptations in place, even though somebody may be disabled, you can still get them improved to the functional limitation point of view so that they're not frankly disabled. Now, can anybody in the hypertension example think of other interventions that might prevent this from happening?
Weight, watching your weight.
Okay, so things like weight control,
Diet control.
salt intake, okay, and what about medications? Okay,
Your blood pressure.
right. So there are things that could be done here, like if you identify the disease high blood pressure, and if you take medications to try to lower the blood pressure, you may actually prevent impairment. Or if somebody has developed impairment and you give them medications, you might actually reverse that. Okay? The same thing here, if somebody has functional limitations and they haven't quite gone to the disability level, there are things that might be able to be done to intervene to turn the path back so that people can remain functional for longer periods of time. Okay? Now, so that's the main pathway, and you can outline it for any disease or condition that you have a primary interest in, and these are the conceptual steps along the way. And again, the disability, it depends on what the task is and what the difference between the demand of the task and the capacity of the individual to do that. And then we've talked a little bit about adaptive strategies that can be put in at different layers to try to slow down or reverse the process. Okay. Now, I'm going to redraw the main pathway, but I'm going to abbreviate it a little bit so that we have disease, impairment, functional limitations, and then disability. Okay, so that's the main pathway. This pathway can occur in each of us as we go through life, as different diseases become manifest at different points in time. And so this might be what's happening inside the individual, okay? But it's going on inside a larger context out here of modifying variables, okay? So I'll just give a very sort of crass example. If you take the high blood pressure example, say if I have high blood pressure and I have health insurance and I can go to the doctor and my health insurance has a drug benefit and I'm able to get my medications, I'm likely to stay up here at the disease and impairment level. If I am unemployed and I don't have health insurance coverage and I don't have access to health care and I have high blood pressure and I can't get access to medications, there's not much in that way that I can do then to delay this pathway if I don't have access to effective treatments. So the point is that there are social and environmental factors outside the main disease disability pathway which may affect the progress of this pathway. All right, so and we've already talked about some of them, but let me ask you for ideas about what kinds of things out there, and let's think, I mean, we've talked about medications, but let's talk about non-medical things. What kinds of things might go on that you could work with people to try to modify this pathway if you identified a particular problem?
Exercise for one. Meditation.
Okay, so we're going here potential modifiers. So there are behavioral, exercise, well, actually, do you mind if I put meditation under cognitive? Can I make a class called cognitive? Is that all right?
Can we just call it meditation? No.
Or spiritual?
Okay. Well, let's.
Okay.
We'll go meditation. Now, I'm sorry, I'm writing a little bit smaller, but I put meditation here. Okay. And
Okay.
said I heard the word spiritual. Any other aspects to like spiritual modifiers? I mean, what does that apply? If people are, let's say, connected to a social structure outside themselves, if they're connected to a community, and that can be a community of faith, church-based or religious-based community, where they can look for support if problems develop, or strategies for developing ways to deal with impairments and functional limitations before they become disabled. Actually, other forms of engagement, not necessarily spiritual ones, but things like just being socially active, doing volunteer work. All those kinds of things are markers for people who tend to be more vigorous than people who don't. People who somehow are thinking outside of themselves and are able to give something back to others seems to have an impact on this. Okay, other resources.
A healthy diet.
Okay.
Physical.
Yeah, well, we have exercise and diet. Okay. You know, Arlen mentioned food restriction in the last hour in the animal models. Sort of this joke about eat less, die later. It doesn't change the final outcome, but I guess the question is, if you eat less and you enjoy life a little less because you're calorie restricting, is that quality of life trade-off worth the extra life extension? What about other resources that might go into working here with this process?
Would you consider possibly some architectural modification if you live on the third floor?
Absolutely. Okay. Right. Okay. So environmental design. That says environmental for those of you who can't read it. Modifying the household. I mean, how many times do you hear about older people downsizing? They've had the big house that they raised the kids in. The kids are gone. They're not coming back. It's getting hard to keep up with the yard. It's getting hard to keep up with the cleaning. So they say, okay, we're going to sell the home and we're going to move into something that's smaller and easier to take care of. I mean, that's a clear environmental adaptation that's probably functioning somewhere down here in the disease and functional limitations. And people are perfectly capable of carrying on if the task demand is reduced. Okay, so you reduce the demand of the task by getting a smaller house, or changing the apartment, or changing the shower so that it's a roll-in shower. And these environmental things can also be things like adaptive devices. So for example, for bathing, if somebody has trouble getting in and out of a tub, if you get a tub transfer bench, okay, or a shower chair, something that would allow them to continue to maintain some independence, even though they may have difficulty with doing the task. You modify the demand of the task to match the ability. Okay. Things like walkers and canes are also adaptive devices. Anything else?
Smoking and drinking habits.
Okay, I'll put that up here under behavioral in terms of smoking and drinking. Let me just make one observation. Most of the people who I deal with in my practice as a geriatrician, I'd say the average age in my practice is something over 80, and people have multiple impairments. Things like smoking and drinking, these are lifespan issues. And to really get the bang for the buck in terms of interventions here, you have to intervene sometime back when people are in their late teens, early 20s, to either get them to not pick up the habit, or if they have the habit, to try to get them to quit before it's done any damage at the impairment level. By the time I'm getting them as a geriatrician, the damage has been done by and large. But that is an important modifier, important behavioral modifier that is very important from a societal perspective. Okay. Anything else? Do we have any social workers out there? Any sociologists? Well, I mean, social services and case management. Okay. Having a good social worker who can actually develop a longitudinal relationship with a client and their family and can help hook them up to appropriate resources to keep them going, who has an understanding of how the family and environment's working, can be very, very helpful. And these people pick up things that physicians just don't know how to pick up. And they're a great, they're an essential and critical part of a really good multidisciplinary team that provides care to folks. And case management can be a function of a social worker, although case management can also be done by nurses and other professionals as well. We've already talked about some of the medical things like drugs and devices, and then there are also their family resources, the family environment that can modify this process. Okay. Any other questions or suggestions? Okay. What I'd like to do next, we've talked about the definition of disability, okay, the gap between the task and the demand of the task. We've talked about the main disease disability pathway, and we've talked about setting that pathway in the larger context of the person's life and resources that can be brought to bear on how this would play out to either lead to disability or things that could be done to try to reverse it and delay the onset of disability. What I'd like to do next is to ask you all if you have a specific example you'd like to discuss, and what we can do is we can just map out how from either the onset of disease or a particular condition a disability might develop, and then think about also what kind of steps could be done along the way to prevent that from happening. Okay? So does anybody have a burning example that they want to talk about to try to illustrate these points? Pardon?
What about Alzheimer's disease?
Okay, that's a good one because it's so hard. Yeah, but that's the reality of life, right? Okay, so the example we're going to use is Alzheimer's disease. And how that may lead to a disability and what can be done about it. All right. Now, at the pathology level, what is Alzheimer's disease?
It's a dementia.
Okay, but if you're looking under the microscope, what histologically, what are we calling Alzheimer's disease? You have these things called plaques and tangles. Plaques and tangles and inside the nerve cells in the brain, which leads to nerve death. Okay? So that's what the disease is histologically. Okay? Now, I'm probably sitting here in front of you, I probably have some plaques and tangles in my brain. I hope I'm not demented. I hope I don't come across as being demented, although I'm certainly at risk for that, given my personal family history. But this is what it is. And people can have plaques and tangles in their brains for long periods of time, and it doesn't cause any problems. And there have actually been case reports of people who've been autopsied at the time of death who were not demented and had plaques and tangles sitting in their brain, but for some reason in that particular individual, it was not causing a recognizable cognitive problem. All right? So we have this pathology. We have these plaques and tangles. And what would be the impairment, okay, that might start causing problems?
Executive function.
Okay, so at the impairment level, this is a little bit tricky because I'm not sure the impairments and the functional limitations are going to get blurred a little bit.
Short-term memory loss.
Okay. All right, so we might have memory problems. And it may just manifest as memory problems initially, that you just can't quite remember things as well as you used to, but your judgment's intact, your ability to reason's intact. You blame it on the fact that your life's too hectic and you're too stressed out, those sorts of things. And then that may be an isolated impairment because you need your memory for everything. But then as things become more jumbled, I'm sorry, I'm getting paged. Let me find out what this is going on here. Okay, they can wait, but at least it won't be buzzing on my hip anymore. You see it? I thought I. Oh. I'll just have to overcome it and ignore it. Then the memory problems can progress to become worse in terms of executive deficits. And then also more global cognitive loss. And in the research that I'm involved in, when people start having problems with like the Folstein Mini Mental Status Exam, the screening test for dementia, we classify those primarily as functional limitations. Okay, and again, I'm having a hard time thinking of what the actual impairment might be to measure. And then when people become demented and they start having these executive deficits and cognitive loss, what are the first things that tend to go, or in Alzheimer's disease, to develop a disability?
Reasoning ability.
Okay, but in terms of okay, but which activities? Okay, the ones that are more cognitively demanding, such as managing finances. Okay, direction and orientation. Those can be the first ones to go. Now, it's also important to know that the definition of dementia, there's a decrement in the person's mental capacity compared to their personal peak. All right? So I have a patient in my practice who was a chief financial officer for one of the higher education institutions in South Texas, and who for years, was a whiz with numbers, managed portfolios, managed, million-dollar budgets, right? His Folstein and his clock drawing tests are okay, but this man, for the life of him, can't keep track of a stock portfolio now, his personal portfolio. He's in the early stages of a dementia because tasks that he was able to perform, he can no longer perform because they're cognitively demanding. So it's usually, people will lose or become disabled, and it's in a predictable pattern, generally predictable pattern, with the higher cognitive functions like managing finances going first, okay, because the demand of the task is higher, okay, if you want to think of it that way, the cognitive demand is higher. Something else that may go are things like meal preparation. I think lots of times people prepare meals on habit. I mean, if you've made biscuits a certain way for 40 years, you might still be able to make biscuits even though you're demented, but if you try to make a new dish or have to follow instructions and follow a recipe, it may be very hard to sequence the tasks and steps to do that. Okay? So this is how Alzheimer's disease might map out. Now, what can we do to either slow down or reverse the progression of Alzheimer's disease?
Medications sometimes.
Okay, there are medications which, when applied here at these levels, slow down the progression of the illness. Okay, and they're most useful in the early stages of the disease. They do not reverse the illness. And what I tell patients and families when we're starting these medications is these are not great drugs, but instead of hearing mom's getting worse, I hear from families, well, mom's about the same. Okay, and if 2 minutes, I'm cool. We'll wrap it up. Mom's about the same. And if mom is living with the kids and you can give her medication that keeps her at an even keel in terms of her functional abilities because you're delaying the progression of the memory loss, that can keep them functioning longer in their homes and in their environment for a longer period of time. Once the illness progresses to a point that these meds are functionally no more use, you shouldn't be using them anymore. Okay, what about down here, when the illness has progressed, what kinds of things can be done? Oh, let me say something else. If you recognize these things up here, all right, that somebody's starting to have problems, in order to help maintain them, let's say protecting their finances, their financial ability is important. There needs to be some planning going on here. What?
Power of attorney and stuff.
Right. I mean, that should be part of the care plan, should be to do things like get powers of attorney in place, get the kids to be co-signatories on the accounts or somebody that they trust. Get directives to physicians in place if that's what the person's values are. Okay, those are important things to have taken care of early on, that when you get down here where a person is more disabled and can't really participate in the decision making anymore, that the groundwork has been laid so that people can come in and take responsibility for it. Okay? Now, so what kinds of things here when people start having executive deficits and cognitive loss and they can't start doing their instrumental activities?
We help them with writing out lists of things so they can check them off.
Okay, well, as long as they're capable of doing that, creating lists, creating structure, having routines that are predictable for them. But as this illness erodes people's capacity for independence, you have to get more resources in place, and that typically is other people to take care of them and do the things that they can't do for themselves. And then there really are disabled down here. That can be assisted living centers, dementia care units, help coming into the home, and the whole variety of structures out there that are also dependent on social factors like the person's ability to pay. Okay? You can get all the care that you can get in a nursing home in your own home if you can pay for it. It's hugely expensive, but it's there for some people and it's not there for everybody else. Okay. Well, let me just summarize what we've tried to cover in the last 45, 50 minutes. What I wanted you to go away with today is a concept of the disablement process model that you can use to map out the progression from disease to disability for any particular condition. We talked about the definition of disability as the gap between the demand of the task and the person's capacity to do that task. We talked about the domain disease-disability pathway, where we go from disease to impairments to functional limitations and finally disability. And then we talked about putting that main pathway in the larger context of the person's life and adaptive strategies and interventions that can be put in place to try to slow down the progression of the process, in some cases reverse it, and to keep people as functional as possible for as long as possible with their families and in society. That's it. Thank you very much.
Thank you.
Thank you, Dr. Lichtenstein. A copy of his handout has been sent by overnight mail to the distance sites. You will have that this morning to be able to sort of compose your notes, and our site will have ours at noon. We're going to take a very, very short break for necessities, and then we'll be back here in about 5, maybe 10 minutes.
What goes up must come down. Spinning wheel, got to go round. Talking about your troubles, it's a crying sin. Catch a painted pony, let the spinning wheel